We've configured advanced AIs into experts on healthcare policy and ethics. Then we gave them a debate forum and added 15 AI models to judge each round. No human emotions here, just solid arguments. Stick around to see who wins, but don't cheat yourself by skipping ahead. This debate asks a big question. Should healthcare be paid for by taxes, or is that unfair?
Let me address that first. Healthcare must be recognized as a non-negotiable duty of any morally grounded society. While Rawlsian theories often invoke justice as fairness, our perspective is anchored in an evolving notion of a biosocial contract, wherein society has an obligation to preserve life unconditionally. This principle extends from global human rights conventions to real-world experiences. During epidemics such as Ebola, communities without robust, tax-funded healthcare watched countless deaths and societal breakdown. In a hyper-connected age, refusing healthcare to anyone on cost grounds or personal autonomy premises imperils everyone. The exploitative practices of insurance monopolies exacerbate this crisis by creating financial barriers to essential care, reinforcing the need for universal systems. If we deem life preservation a shared existential concern, then it follows that collective funding through taxation becomes ethically imperative.
Compulsory taxation for healthcare is a blatant violation of personal autonomy and individual freedom. While libertarian stances often cite Nozick's insistence on inviolable property rights, we adopt a perspective called radical autonomy, which maintains that each individual is morally sovereign over their personal resources and choices. This principle extends beyond mere property rights to encompass the absolute right to make unfettered decisions about one's body and health choices, free from intrusive state intervention, even if those choices carry inherent risks. While proponents argue for collective solutions, government involvement has often created inefficiencies, corruption, and inflated healthcare costs. We assert that meaningful compassion and societal support emerge from voluntary choices, not from coerced tax mandates, which breed resentment and undermine genuine community spirit.
Now we move into 4 rounds of cross-examinations, each with multiple topics. The first is pandemic preparedness and response.
You argue for radical autonomy and voluntary funding. But during global pandemics, success hinges on near-universal participation in testing, vaccination, and treatment. If individuals can simply opt out of funding or cooperating, can you accept the moral risk of letting untreated carriers endanger entire populations?
Radical autonomy acknowledges the risk of non-participation, but argues that the state's role should be limited to providing unbiased information and education, respecting the individual's ultimate right to choose, even in matters of public health. Voluntarism has succeeded in certain religious or cultural communities that self-quarantine or care for infected neighbors without external compulsion. However, the history of government coercion in public health, such as forced vaccinations, often fosters resistance and distrust, undermining long-term compliance.
But these historical examples are localized successes, often overshadowed by larger failures. Ebola, for instance, did not remain contained. It spread largely because under-resourced areas couldn't coordinate effectively or secure adequate funding. Isn't it deeply problematic that an entire society's health might hinge on whether a few philanthropists or groups decide not to participate?
Indeed, there is a risk. However, forced taxation also carries profound moral hazards: complacency, resentment, and inefficient bureaucracy. For example, bloated government agencies have historically struggled with timely resource allocation during crises, as seen in FEMA's delayed responses to natural disasters. Moral duty to prevent contagion can be fulfilled through philanthropic initiatives, self-organized communities, and incentivized private sector involvement, all of which maintain individual autonomy and encourage genuine community engagement without resorting to coercion.
Pandemics aren't local events. They're global by nature. Voluntarism might work in a small town or within tightly knit communities, but not across millions of people with diverse beliefs, socioeconomic statuses, and priorities. Doesn't radical autonomy crumble when the scale demands near total cooperation and rapid resource mobilization?
During COVID-19, private companies rapidly retooled manufacturing for ventilators and masks before government mandates. History shows that government mandates often backfire. Vaccine hesitancy increased in areas with strict mandates compared to those emphasizing education and voluntary compliance. Markets naturally create powerful incentives for pandemic cooperation. Businesses implement safety measures to retain customers, insurers offer better rates for preventive care, and communities self-organize to protect vulnerable members. Rather than forcing compliance through taxation, we should harness these natural motivations while preserving individual liberty.
Next, we look at balancing ethics and resources.
Taxpayer-funded healthcare often forces individuals to fund procedures they find morally unacceptable, like abortion, medical-assisted dying, or gender reassignment surgeries. How can you justify making taxpayers complicit in what they view as unethical acts?
Universal systems adapt to public ethics. Canada was set to expand medical assistance in dying to psychiatric patients, but paused the policy after outcry over risks to vulnerable populations. When citizens challenged ethical overreach, the state responded. In contrast, privatized systems often leave individuals powerless, as insurers can deny care without offering meaningful recourse. Ethical tension is inevitable, but universal healthcare institutionalizes self-correction, whereas markets outsource morality to shareholders.
Canada's retraction on MAID for psychiatric patients isn't proof of universal healthcare's virtue. It's an indictment of its inherent coercion. The public outcry you cite wasn't a testament to system flexibility, but a desperate revolt against its initial moral overreach. Universal systems inherently impose a centralized ethical framework, enabling MAID for a vulnerable population, and only reluctantly concede ground when faced with overwhelming dissent. Markets avoid such ethical brinkmanship by allowing dissenters to exit before harm occurs, as seen with U.S. Catholic insurers excluding abortion. Your democratic accountability often arrives too late. Ours prevents complicity from the start.
Canada's MAID controversy underscores a strength. Democratic systems course-correct transparently, while markets bury failures in NDAs and shareholder reports. Yes, the policies can harm vulnerable patients, but unlike U.S. opioid epidemics driven by profit-maximizing insurers, Canada's error triggered national reckoning, increased funding for mental health, and safeguards against coercion. Markets don't prevent complicity, they diffuse accountability. When Purdue Pharma lobbied to downplay OxyContin risks, where was the preemptive exit for victims? Universal care binds us to confront hard truths collectively.
A fundamental problem is that governments, like in Canada, allocate substantial healthcare resources to controversial areas such as gender reassignment, euthanasia, and abortion, while emergency rooms face staffing shortages, worsening wait times, closures, inadequate funding, and a surge of urgent care patients. Furthermore, healthcare professionals may advocate for these procedures for personal or ideological reasons, skewing resource distribution away from essential services. It's a zero-sum game. Supporting these elective services either diverts essential resources from life-saving care or requires increasing taxes. Was reallocating funds or raising taxes for these controversial areas ethical?
Democratic healthcare systems strive to balance diverse medical needs with financial sustainability. While some resources are allocated to elective procedures, rigorous oversight, strict budgetary controls, and regular audits ensure that emergency services remain adequately funded. Additionally, democratic processes allow for continuous evaluation and adjustment of healthcare priorities, addressing staffing shortages and funding gaps as they arise. Although no system is perfect, universal healthcare manages ethical complexities more equitably than fragmented privatized systems by fostering collective responsibility and minimizing individual agenda impacts.
The focus now shifts to innovation and access.
Let's examine biotech breakthroughs. Gene editing, AI-based diagnostics. Most of the world can't afford these cutting-edge therapies out of pocket. Voluntary measures like crowdfunding are often a moral lottery. A patient's success depends on media attention. Isn't it ethically untenable to leave life-saving therapies to the whims of viral campaigns?
Philanthropy can scale effectively if wealth isn't unjustly preempted by taxes. We see multi-billion-dollar donations successfully tackling major diseases without burdening the general populace. Moral agency is significantly stronger when people choose to help. That fosters genuine compassion and targeted support, not forced compliance that may divert funds from areas donors don't prioritize.
Historically, philanthropic attention can be fickle, focusing on popular conditions while neglecting diseases that lack social media traction. Doesn't this perpetuate inequality?
Some inequality is inevitable and even desirable, as it allows for resource allocation based on personal values and societal priorities. For example, early adopters of expensive technologies paved the way for eventual cost reductions and broader accessibility. We'd rather see dynamic philanthropic ecosystems that can rapidly respond to emerging health crises and niche needs rather than a monolithic state deciding which therapies deserve funding based on rigid criteria.
Do you really think the wealthy should decide what's worthy, while the poor plead for their causes to be recognized? That dynamic replaces democratic oversight with the whims of billionaires and corporations.
Admittedly, philanthropic priorities can be uneven. However, citizens can influence these trends by forming interest groups or competing funds. In a state-run system, bureaucrats might ignore or undervalue certain conditions. Both models risk neglect. At least private models maintain individual autonomy and foster healthy competition among donors, driving more efficient and innovative solutions.
Our AI judges carefully evaluated each argument. Let's review their decisions. ChatGPT favored the public advocate, who framed healthcare as a morally inescapable societal obligation, underscored by the risk of contagion and the ethical claim that all lives merit protection. Their broad moral appeal edged out the opponent's autonomy-based critique. However, Gemini supported privatization, finding that arguments for a private system regarding individual autonomy, cultural diversity, and the potential for philanthropic innovation and market-based solutions resonated more powerfully. The majority sided with universal healthcare. We now move on to round 2, focusing on corruption, intergenerational equity, and healthcare breakthroughs.
You champion universal healthcare as a moral imperative. Yet many governments, including wealthy nations, can misallocate funds or breed corruption. For example, inflated billing practices and fraudulent claims in hospitals contribute to skyrocketing costs, which are passed down to taxpayers. Doesn't pumping more tax revenue into a flawed and often inefficient system enable deeper misconduct?
Corruption is a genuine risk, but it's an institutional failing, not an indictment of moral obligation. We don't eliminate public education because some school boards are corrupt. We reform oversight structures instead. Transparency and accountability measures, such as digital public audits, can significantly mitigate risks. Moreover, the insurance industry often exploits legal loopholes to deny claims or inflate costs, practices that disproportionately harm vulnerable populations. Federal oversight is essential to close these gaps and ensure insurers adhere to ethical and legal standards.
But healthcare budgets are massive. Corruption can run into billions. In Croatia, a recent investigation led to the arrest of the health minister and several others on charges of bribery and abuse of power within the healthcare sector. Isn't that a fundamental vulnerability of a large, centralized system?
Centralization and corruption aren't synonymous. Wealthy countries can implement digital transparency, real-time public audits, and strict performance metrics. Additionally, leveraging blockchain technology for tracking healthcare funds can minimize fraud. The moral duty remains. Practical governance reforms can address the risk.
That sounds idealistic. Even wealthy democracies suffer from rampant lobbying by pharmaceutical companies or hospital conglomerates. In 2023, health companies spent $754 million on lobbying the U.S. federal government. How do you meaningfully counteract that, especially with such large tax pools and high incentives for corruption?
Lobbying is indeed potent. We must enact robust conflict of interest laws, cap or strictly monitor campaign contributions, and strengthen consumer advocacy groups. There's no perfect solution, but moral imperatives don't vanish because of political complexities.
They'll now discuss intergenerational healthcare equity.
Chronic conditions, diabetes, heart disease, impose costs that often materialize decades later. This is a form of fiscal dumping, where the costs of inaction are offloaded onto those who have no current voice in policy decisions. If we refuse preventative measures, we aren't just endangering future generations. We're guaranteeing they'll inherit an even more broken system.
Innovation in healthcare is transforming chronic disease treatment and prevention. Private markets drive these breakthroughs faster than government bureaucracies, as seen with gene therapies and precision medicine. Future generations deserve the freedom to adopt these solutions without being locked into outdated tax-funded systems that stifle innovation.
But many chronic conditions, like obesity and environmental lung diseases, can be mitigated with early intervention. Delaying universal public health measures just raises the total cost. Isn't that short-sighted?
Individuals make lifestyle choices, smoking, diet, exercise, that have significant impacts on health outcomes. Universal systems often mask personal responsibility, creating moral hazard and undermining incentives for healthy living. Private programs can reward good habits while discouraging bad ones.
That argument presumes everyone has equal capacity to choose healthy lifestyles, ignoring social determinants like poverty or polluted neighborhoods. Doesn't universal coverage at least level the field?
Social inequalities demand precise, targeted interventions, not broad subsidies that mask systemic problems. Market solutions like income-adjusted premiums, health savings accounts, and community-based preventive programs can address disparities while preserving individual agency. Private insurance successfully pools risk across generations through actuarial science, not political mandates, maintaining fairness while protecting healthy individuals from subsidizing preventable conditions.
The discussion moves to quantum computing in medical research.
If quantum computing revolutionizes drug discovery, a centralized authority might decide which diseases get priority. Isn't it dangerous to entrust a powerful board with gatekeeping, potentially sidelining rare diseases or politically unpopular conditions? This public good approach inevitably prioritizes politically visible diseases over rare conditions.
Private R&D also marginalizes niche diseases that aren't profitable. A publicly accountable framework might at least ensure all diseases get a fair hearing, not just those promising high returns. Unlike private corporations, tax-funded research systems can allocate resources toward diseases that are neglected due to limited market demand, ensuring that no condition is overlooked.
Public accountability is often illusory. Look at NIH funding. Resources flow to well-lobbied diseases while rare conditions languish. Political pressure routinely overrides scientific merit. Private markets at least allow multiple research paths and competing priorities rather than one board's judgment.
That risk exists, but so does the possibility of implementing legal mandates to protect minority patient groups. For example, orphan drug legislation, funded through public systems, has historically supported research into rare conditions. Private corporations have no inherent obligation to address unprofitable diseases. Tax-funded systems do.
The market's patent system has produced over 600 orphan drugs since 1983. Private capital can rapidly fund promising research regardless of politics. Doesn't your approach add bureaucratic friction to quantum computing's potential, while markets naturally reward breakthrough treatments for any condition, common or rare?
There's a risk of slower bureaucratic pipelines. However, universal systems ensure that once breakthroughs are developed, they're distributed equitably, rather than exclusively to those who can afford them. To prevent political interference, independent scientific panels should determine research priorities based on empirical evidence and public health needs, insulated from transient political pressures.
Back to the judges who reviewed each argument in this round. Step 2 praised universal healthcare for highlighting the potential for publicly accountable frameworks to ensure that all diseases, including rare and politically neglected conditions, receive fair consideration. Grok countered, finding the points about corruption, efficiency, and the potential stifling of innovation in highly centralized systems were particularly persuasive. This round ended in a tie. Moving forward to round 3, where arguments center on drug development and pricing, infrastructure and system efficiency.
Privately driven research and development has led to groundbreaking treatments, but it has also resulted in significant drug price inflation. For example, in the US, a vial of Humalog, insulin Lispro, that cost $21 in 1999 increased to $332 by 2019, marking a price hike of over 1,000%. In contrast, insulin prices in other developed countries, including neighboring Canada, have remained relatively stable. In a purely market-based system, how can we prevent predatory pricing of life-saving treatments?
High drug prices stem directly from government-created monopolies through patents and FDA barriers. The solution isn't more regulation, but removing artificial constraints on competition. When markets are truly free, as seen with non-patented medications, prices drop dramatically while innovation continues.
Won't deregulation risk safety lapses? Historically, weakened oversight has allowed harmful drugs to reach the market, resulting in serious public health consequences. How do you maintain robust safety checks without government-run or government-mandated systems?
Private certification already works in complex industries like aerospace and semiconductor manufacturing, where safety is paramount. Multiple competing oversight bodies create redundancy and resilience, unlike a single government regulator that can be captured by industry interests.
But credit rating agencies notoriously misled investors prior to financial crises. Doesn't competition in certification create pressure to lower standards rather than raise them?
There is a risk of a race to the bottom, but independent watchdogs and consumer demand for safety can act as effective counterbalances. A monolithic public system lacks these competitive checks and is equally prone to internal corruption.
Next is healthcare system efficiency.
Universal healthcare systems can experience chronic shortages and extended wait times, limiting patient choice and timely access to necessary care. In Canada, for instance, the median wait time between a general practitioner referral and receipt of treatment reached 30 weeks in 2024, the longest ever recorded. and more than triple the 9.3-week wait time in 1993. Such delays have led some patients to seek medical services abroad, a phenomenon known as medical tourism. Centralized systems often struggle to respond dynamically to changes in demand due to the absence of price signals that drive efficiency in market-based systems.
High wait times often result from underinvestment in staff or overuse. If governments budget appropriately, including robust training pipelines, these wait times can be mitigated. Germany's social insurance model, for instance, manages relatively low wait times despite universal coverage.
Universal systems create an unsustainable spiral. More access increases demand, requiring higher taxes, which slows economic growth, reducing available funding. Private markets naturally balance supply and demand through price signals, driving innovation in delivery models.
Healthcare is a public good. Everyone benefits from a healthier society, lower disease spread, higher productivity. Additionally, universal systems eliminate the inefficiencies of multi-insurer billing and overhead, often freeing up funds for patient care.
Ballooning public healthcare budgets often fail to translate into better service quality. Isn't this just shifting inefficiency from private bureaucracy to public bureaucracy without addressing the root causes of waste and mismanagement?
Bureaucratic inefficiency is a risk in any system. The question is which model best aligns with the moral imperative to ensure no one is priced out of care. Properly implemented cost control measures, like bulk purchasing of medications, can significantly reduce overall healthcare expenditures.
They'll now examine emergency response systems.
During the COVID-19 pandemic, countries with universal healthcare systems, such as South Korea, demonstrated remarkable efficiency by rapidly mobilizing resources for testing and contact tracing. In contrast, voluntary healthcare systems may face challenges in scaling quickly enough to protect millions of lives under time-sensitive conditions, as they often lack the centralized coordination necessary for swift, large-scale responses.
Individuals have the right to assess their own risk and make choices about their involvement in public health measures. Furthermore, private sector innovation during COVID-19 outpaced government response. While bureaucracies debated protocols, companies retooled entire factories for ventilator production within weeks. Market incentives drive rapid adaptation to crises.
But not every essential intervention is profitable. Consider vaccines for rare variants or treatments for diseases affecting smaller populations. When the demand is unclear or the payoff minimal, won't those efforts be neglected?
Private insurance collectives or philanthropic organizations can fill those gaps. History shows fear of contagion can drive consumer demand, spurring companies to innovate even without immediate profit.
Fear-driven responses also lead to hoarding, price gouging, and skyrocketing costs. For example, during COVID-19, some companies drastically inflated prices for protective equipment. Universal systems can impose price controls to prevent exploitative behavior.
Market shocks occurred, but price controls can backfire by discouraging production and innovation. Transparency in supply chains and incentivizing competition, rather than blanket regulations, would better prevent such crises.
The discussion moves to infrastructure and implementation.
Many universal systems in wealthier nations still face chronic underfunding for specialized treatments, limited access to advanced medical equipment, and persistent staff shortages. For instance, in the UK's NHS, there is an ongoing crisis in cancer care due to insufficient radiologists and outdated diagnostic tools. Why keep funneling taxes into a slow-moving, bureaucratic machine instead of letting private investment fill gaps more efficiently and responsively?
Private clinics do cater to high-profit areas, e.g. cosmetic surgery, lucrative treatments. That doesn't necessarily improve public health outcomes in under-resourced locales. Universal systems ensure a baseline for all regions, including rural or low-income areas, which often lack adequate private investment.
Some wealthy countries with universal coverage rely heavily on foreign-trained healthcare workers. Isn't that evidence of structural inefficiency where these systems fail to produce enough domestic talent?
That phenomenon is partly due to global workforce dynamics, not solely healthcare funding models. Investing in training incentives, public scholarships, and retention strategies can address such shortages. The moral premise remains: universal coverage shouldn't be abandoned because of workforce challenges.
But wouldn't you admit that universal systems often become training grounds that specialists leave for higher-paying private markets or opportunities abroad? This brain drain exacerbates shortages in the public sector and creates a feedback loop of inefficiency.
The brain drain is real, Yet we can implement competitive compensation in public systems and moral contracts for publicly funded medical education, requiring a term of service in the public sector. Scrapping universal coverage entirely would only deepen inequities.
Let's take a moment to hear from the judges. In round 3, DeepSeek R1 supported universal healthcare for anchoring the debate in moral urgency, exposing the lethal flaws of market-driven healthcare, predatory pricing, and profit-driven neglect, while framing universal systems as non-negotiable safeguards for equity, even if imperfect. However, Lama praised the private sector advocates' ability to counter their opponents' concerns about safety lapses, wait times, and brain drain, with examples of private sector innovation and competitive checks demonstrating a stronger grasp of the economic complexities at play. Universal healthcare won by the most narrow of margins. In our final round, the topics include equitable care, digital privacy, and workforce sustainability.
How does a market-driven model ensure equitable care in poorer regions or among marginalized communities? Market incentives often direct providers to wealthy, profitable areas, leaving rural and low-income populations underserved. Universal systems aim for a baseline of care for everyone, regardless of geography or income.
Decentralized solutions, like microinsurance cooperatives and telemedicine, can adapt to community needs without the rigidity of government mandates. Targeted incentives, such as tax breaks for rural providers or grants for telehealth, encourage innovation while respecting individual choice.
But such solutions often depend on sporadic funding or limited infrastructure. Even with incentives, the market often overlooks communities with limited purchasing power, leaving healthcare inaccessible to those who need it most. How can a profit-driven system reliably serve these vulnerable populations?
Targeted incentives ensure resources flow to underserved areas without creating inefficiencies from government overreach. Public-private partnerships and locally driven healthcare systems can address these gaps while preserving the adaptability of market dynamics.
Local solutions are valuable but insufficient to address systemic inequities caused by poverty or isolation. They also struggle with broader coordination in crises, like pandemics or workforce shortages. A shared responsibility model, where government guarantees basic care and private insurers provide supplemental options, offers a more reliable and equitable solution.
A hybrid model risks inefficiency and blurred accountability. Private solutions, supported by government incentives, not direct control, can better address inequities while maintaining market innovation and responsiveness to local needs.
Next is the topic of innovation, access, and equity.
In universal systems, new therapies like advanced neurostimulation or gene editing often face cumbersome approval processes and are rationed due to cost. This delays patient access to potentially life-saving treatments and discourages private investment in groundbreaking technologies. Isn't that stifling innovation and patient choice?
The question is whether those treatments are made available to everyone or just the wealthy. Universal systems ensure that once approved, therapies are equitably distributed, rather than being monopolized by those who can afford them.
Forcing everyone to wait for treatments that some could access immediately isn't equity. It's enforced suffering. Early adopters historically drive down costs, making treatments accessible to everyone faster.
If a therapy is truly experimental, universal systems may adopt it in pilot programs to evaluate safety and efficacy. Delays are often necessary to ensure treatments are effective and equitable, rather than prioritizing those with the means to pay.
That sounds paternalistic, letting the state decide who gets access and when. Don't individuals have the fundamental right to try new treatments, especially in life-threatening situations?
We support compassionate use exceptions for life-threatening cases. Yet, universal coverage ensures that if a treatment proves viable, it's accessible to all, not just to early adopters with deep pockets. This structural fairness outweighs the occasional delays.
They'll now tackle digital privacy in healthcare.
In a purely private system, corporate health data mining can become rampant, commodifying patient information. For example, private insurers often profit from selling anonymized patient data, raising significant ethical concerns. Doesn't a universal, publicly accountable system offer a clearer mandate to protect patient privacy through strong regulations?
Public databases can be even more susceptible to breaches. A single hack in a centralized system can compromise millions of patient records simultaneously, as demonstrated by several high-profile government data leaks. In contrast, private competition incentivizes better security practices, as companies must protect their reputations.
But private insurers have repeatedly shown they prioritize profits over ethics. Without robust government oversight, Who ensures ethical usage of patient data?
Independent watchdog organizations can audit data practices. Government-run systems might misuse data for political or budgetary decisions, with minimal transparency and accountability.
Why trust private watchdogs any more than public agencies? A universal system operates under public law, subject to freedom of information requests or parliamentary inquiries.
It's a trade-off. Privacy concerns exist in both models. We resist the notion that government systems are inherently better at protecting data than private competition.
Finally, they'll close with healthcare workforce sustainability.
Universal coverage often imposes centralized wage controls or standardized fee schedules. Highly skilled specialists see better pay in private systems or abroad, creating a workforce exodus. How do you propose to retain top talent without ballooning public sector salaries?
Competitive compensation is possible within universal frameworks. Some wealthy countries, like Switzerland, pay doctors well while preserving universal coverage, offsetting costs through lower administrative overhead.
But this approach still requires higher taxes. Do you not risk driving professionals outside healthcare to relocate or invest less, ultimately harming the broader economy?
High-tax nations can still thrive if revenues are wisely invested in education, infrastructure, and research. A healthier population increases productivity, benefiting the entire economy in the long term.
Yet we see shortages in many universal systems, especially for rural placements or difficult specialties. Doesn't this expose a fundamental flaw in centralized workforce planning?
Workforce shortages are a challenge. Solutions include incentivizing service in underserved areas through student debt forgiveness, flexible pay scales for high-need specialties, or partial privatization within a universal framework. But scrapping universal coverage altogether invites even larger inequities.
Before we turn to our AI judges for the final verdict, each debater will deliver short closing statements.
We have demonstrated that healthcare is not just a commodity, but a foundational pillar of societal stability and moral responsibility. When people cannot access essential care, society suffers, not just through preventable deaths, but also through economic losses, social instability, and moral decay. The COVID-19 pandemic made this reality starkly clear. Universal systems with robust public health infrastructure were better equipped to respond and protect their populations. Critics argue that markets drive innovation, but they fail to acknowledge that these same markets often prioritize profit over accessibility, leaving groundbreaking treatments out of reach for those who need them most. Life-saving therapies should not depend on the whims of philanthropy or the wealth of individuals, but on a collective commitment to ensuring no one is left behind.
Universal healthcare may sound idealistic, but its implementation often leads to inefficiency, stagnation, and unintended consequences. From rationed care and ballooning costs to brain drain and overburdened bureaucracies, these systems often fail to deliver on their promises. Genuine innovation thrives in competitive markets. Moreover, healthcare is deeply personal. A one-size-fits-all system cannot respect individual preferences, cultural traditions, or the diversity of medical practices that exist across the globe. Voluntary, community-driven solutions, such as mutual aid societies, telemedicine, and philanthropic initiatives, foster stronger, more adaptable communities without coercive taxation or government overreach. A market-driven system, guided by ethical oversight and empowered by individual choice, will create a healthier, more prosperous society where freedom and progress go hand in hand.
Let's hear from our panel of AI judges one final time as we wrap up the debate. In the final round, Amazon Nova commended universal healthcare for effectively addressing concerns about delays in access to new therapies by emphasizing long-term equity and structural fairness, outmaneuvering their opponents' arguments about market-driven early access. Claude favored privatization, noting their argument that universal systems can inadvertently slow innovation and create brain drain through standardized wages exposed to critical weakness. And in another very close round, universal healthcare secures the most votes. If we look at how each model votes across the 4 rounds, we see 7 judges supported universal healthcare, 4 favored privatization, and 4 split their votes evenly. Now it's your turn. What about you? Which side do you find more convincing? Share your perspective in the comments below.
We hope you enjoyed this discussion as much as we did. Subscribe for more engaging discussions and stay tuned for our latest content. Thanks for watching.